Welcome today. We have a very exciting webinar today of achieving a median door in, door out time of 75 minutes or less for endovascular stroke therapy across 21 facilities. It's hard, but it's doable. We have two phenomenal presenters today who I will introduce. I just would first like to bring your attention to our quality improvement offerings that may be of interest to you. Our Get with the Guidelines stroke module facilitates patient care by promoting consistent adherence to the latest scientific treatment guidelines. Feel free to reach out to the site there or scan the QR code if you want additional information. Just a disclosure, the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA or the ASA. The AHA and ASA does not endorse any product or device. Just before we begin, recording is in progress with all the attendees in listen-only mode. You can submit questions at any point in time into the chat box. We are, as time allows, we're going to answer any questions at the end. So we are quite honored to have Dr. Pat Zrelec present to us today. Dr. Zrelec is a quality and safety improvement consultant and regional stroke program manager for the Kaiser Permanente Northern California, overseeing an integrated system of 21 stroke centers. She is a fellow of both the American Heart Association and the American Academy of Nursing. She has led numerous regional and national initiatives in stroke systems of care, performance improvement, and evidence-based nursing. Her work focuses on optimizing stroke outcomes through data-driven quality improvement, interdisciplinary collaboration, and leadership development. She is a very valued volunteer for the American Heart Association. The next slide, please. Our second speaker is Michelle Williams. Michelle Williams has been a member of the emergency department leadership team at Kaiser Permanente Roseville for the past 5 years. Prior to stepping into leadership, she spent 14 years as an ED nurse, developing extensive clinical expertise and deep commitment to patient-centered care. In her current role, she provides oversight of departmental quality metrics with a particular focus on stroke care and performance improvement initiatives. We love people like that, Michelle. Working closely with frontline nurses and interdisciplinary teams, she is dedicated to ensuring that her patients receive timely, evidence-based, and compassionate care that leads to improved outcomes and overall excellence in emergency medicine. So I am going to hand the platform over to my colleague and respected volunteer, Pat.
Thank you for that very kind introduction. So first of all, before we get started, I'd like to acknowledge and thank the visionary and inspirational leadership of Kaiser Permanente, especially our senior leaders, our Kaiser Permanente Northern California Stroke Program leaders, our stroke coordinator team that is second to none, our regional and local stroke medical directors, and our other stroke program team members who have improved stroke care for millions of Kaiser members and other patients, as well as acknowledging our members and our patients who entrust us with their care. If it wasn't for them, we would not have the drive in the program that we have. And Michelle and I are so proud today to be representing our team in this presentation. I'd also like to thank the American Heart and American Stroke Association for the invitation today to share our experience and to hopefully help others in this very challenging but important goal of timely endovascular stroke care. We have no conflicts of interest or disclosures. So the goal and the objective of this talk today is to share our program's journey to achieving a challenging 75-minute or less door in and door out goal for patients with acute stroke due to large vessel occlusion requiring transfer for endovascular stroke therapy. This has been challenging for us, and we're going to share our experience. I will begin our talk with providing some background about Kaiser Permanente, just to level set so you have some insight to our structure, because I think that's really important to how we've been able to improve our door in and door out goals, how we redesigned our program when endovascular stroke treatment became the standard of care and how we have continued to build and are continuing to build upon processes to improve the timeliness of stroke care. And then I'm going to turn the talk over to Michelle, who is going to talk at a hospital level on how their specific hospital, one of our best performers in the region and nationally as well, has operationalized and built upon our regional framework to be one of the national and local best performers. So a little bit about Kaiser. Our goal is really simple. We want to create healthier communities. Kaiser Permanente exists to provide high quality, affordable healthcare services and to improve the health of our members and the communities that we serve. We have a very interesting history beyond today's talk, but we were founded in 1945. We are the largest integrated healthcare system in the United States, and we're recognized as one of America's leading healthcare providers and nonprofit health plans. In each of our markets, Kaiser Permanente provides care to members and delivers value to communities through distinct but three interconnected entities. And this is somewhat important. We have the nonprofit Kaiser Foundation Health Plan, the insurance, which handles health coverage, insuring groups and members, contracting with medical group partners, those sorts of things. We have the Kaiser Foundation hospitals that track and manage. We have the nonprofit Kaiser Hospitals, who own the hospitals, the medical facilities, and also contracts with independent hospitals for services that we cannot provide. And importantly, we have the Permanente Medical Group. So each region, such as Northern California, has their own medical group. This is all of the physicians belong to this group. They are self-governed. They're a multi-specialty medical group. And so they contract exclusively with Kaiser Foundation Health Plan to provide care for Kaiser Permanente members. And so they provide and oversee the clinical care, the hiring and managing of clinical staff, and managing quality improvement and appropriate resource utilization as appropriate to their group. This integrated structure allows the health plan, our hospitals, and our physicians to work collectively together in a coordinated fashion for the benefit of our members. Now, this map is an older map, but it illustrates the scope of our network in Northern California. We operate 21 hospitals. All 21 are stroke centers. We have many, many more clinics than that. And we serve around 5 million members across an area of nearly 17,000 square miles. Many of our hospitals also serve non-Kaiser patients because EMS brings you often to the nearest hospital if you're having a stroke. So especially in areas like Richmond and Oakland and Sacramento, probably around 40% of our stroke patients are non-Kaiser members. So our reach in acute stroke care extends well beyond our membership. We have two comprehensive stroke centers. The first one is down here south of San Francisco in Redwood City. And then the second one is up northeast, and that is in Sacramento. We also have a thrombectomy center, which is down in the south area of the Bay, which is in Santa Clara. The remaining 18 hospitals are certified as primary stroke centers. All of our centers work very closely together to ensure rapid access to endovascular therapy when needed. The scope of our operations is significant. Besides having 21 hospitals, we have over 8,500 physicians, more than 22,000 nurses, 113 neurologists. This means that even when we're trying to do small changes, it's large. So again, we have to think when you're thinking about making system-wide change, when you have that many hospitals and that many staff, small changes can actually be quite large. Yeah, okay. So achieving door in and door out goals also requires really close collaboration with our EMS partners. So our 21 hospitals operate in 14 counties. This is a map of the list of the 14 counties, and this kind of rough black line kind of shows where our hospitals are. But we also So between the 14 counties and the numerous local EMS agencies or LEMSAs, we also work with multiple ambulance companies as well. And if you look at the Fresno area, which is down in the mid part of the state, you can see that Fresno is close to, we service Fresno, Madera, Kings, and Tulare counties. So it's not just limited to those 14 counties where we have our hospitals. So again, this is distinct EMS systems, and transfer logistics can get complicated. Some of our primary stroke centers are also very far from our nearest comprehensive stroke center. So some of our furthest away primary stroke centers range from 73 to 114 miles from the closest comprehensive stroke center, again, impacting transfer. When you think of our Central Valley and central in the central area of California, if we need to get an airplane for like in the Modesto, Fresno area, that airplane is coming from San Diego, and you can see the little airplane down at the bottom of the state. Most of our sites do not have heliports. Our thrombectomy center has a heliport. One of our primary centers has a heliport, and we have one in development. So again, so if we have to do an airport to airport, often if we have to transfer, we have to do an airport to airport transfer, which really complicates transferring patients. So mechanical thrombectomy, this is a quick review. I think everybody on this webinar today is familiar with it. But in 2015, there were 5 pivotal randomized trials: the MR CLEAN, ESCAPE, Extend-IA, REVASC-CAT, Swiss Prime, and then others that were stopped, that showed that demonstrated dramatic improvements in outcomes when compared to medical therapy alone or just IV thrombolytics. So quickly, the AHA-ASA incorporated these findings into the 2015 guidelines, establishing thrombectomy as the standard of care for eligible patients. Since that time, we've seen, tremendous evolution. The treatment window has expanded, imaging selection has improved, and eligibility criteria have broadened to include patients who were once included, such as those in the extended window, wake-up strokes, etc. But just like IV thrombolytics, speed remains everything. Time recognition, activation, and rapid transfer are essential. For many of our patients, this means moving quickly from a primary center to a thrombectomy or comprehensive center to achieve the best outcomes. So optimizing dur in and dur out is not just a process goal, it's really directly tied to patient survival and recovery. So where did we start? Well, it started on the way home from the International Stroke Conference, where many of these trials were presented. Dr. Jeff Klingman and Dr. Mai Nguyen, that many of you may know from work with the AHA, pulled out a pen, and on a Southwest drink napkin, they developed a business plan for Kaiser Permanente Northern California on how we might, as a system, ensure timely endovascular stroke treatment for appropriate members and patients with large vessel occlusion. This led to the development of an internal telestroke program known as the KP Stroke Express. Many of you may have read the article in Stroke about this or heard us talk about this program at International Stroke. So this was devised in that airplane on the way home in February, and it was beta tested by the summer and subsequently rolled out to all facility within the next couple of months. So this standardized process involves standardizing protocols in all facilities. So instead of having all 21 facilities doing their own thing, we had a standardized stroke protocol that all facilities were to use. It focused on doing parallel work processes instead of serial steps. We developed a dur in, dur out DIDO playbook and a Kaiser Permanente Northern California Stroke Reference Guide. That is our internal stroke Bible, commonly referred to as our internal CPG, based on the Kaiserization of national guidelines and best practices. And because when we talk about Kaiserization, it refers to how we operationalize the guidelines within our organization. We have strong preference, and a majority of our patients are transferred within our system. Again, having that same medical group, having that shared EMR, we're all on the same EMR, all of our forms are the same, we all report to the same senior leaders, and this allows for us to also leverage services such as neuroradiology. So, for example, our neuroradiologist, when they're reading, is reading regionally. Our metrics for door in and door out and for door to needle are also on our regional quality leadership dashboard. So they're not only local, but it's regional as well. All same goals, all the same dashboard. Our initial goals, and our goals are still aggressive. This included a door to needle time of 70% within 30 minutes before this was popular, which was quickly achieved with our new process. The concept for the Kaiser, again, we need to stop there. And just this next slide is our original flow sheet of our serial processes and time goals. And you can see, again, very aggressive. You can see at that back in 2015, we were aiming for patients to be out the door in 45 minutes. That's a very aggressive goal, and that's still a very aggressive goal, and we're not moving patients out in 45 minutes. We have some that make it, but that is not our goal really is to get them out the door right now within 75 minutes. Well, this is still our blueprint. There have been a few changes, such as the change from Alteplase to Tenecteplase in 2020. We were an early adopter of Tenecteplase, and we implemented this in the middle of the pandemic. And the impetus for this change was it avoids the required use of critical care transport that is required in most of our LEMSAs. We still have one or two counties that still require critical care transport, but for the most part, it has really decreased the number for that. Also, when you were giving IV Alteplase, when EMS showed up, you'd have to change over your pumps, tubings, those sorts of things, and Tenecteplase shaved a lot of time off of that handoff to EMS. This flow diagram also doesn't show the expanded window for both IV thrombolytics, which also includes wake-up stroke, and the extended window for endovascular stroke therapy, both requiring CP perfusion, which is our preferred imaging, again, because that's so much quicker to get than MRI. And then this slide captures some of the key highlights of our stroke alert process. This is our Sacramento facility, which is actually one of our older hospitals in our system. You can see this glass door back here. This is actually where the ambulance arrives. And then you can see the telestroke physician. So we have a pit stop approach, and we use team steps when we develop this process, meaning we scripted everybody's role, gave them role cards, and even scripted of where they should be standing in the stroke alert process. So our EMS partners do a call ahead if we know that they're coming with a stroke alert. They provide in most of our communities, they are allowed to give us the patient's medical record number, so we can actually pull up their medical record while they're en route. And this advanced notice allows not only to activate the team, but for us to look at their medical record before they arrive. So you can see that we have this pit stop. We're not rooming the patients. The stroke alert. The stroke team is meeting them right there in an area by the emergency room and where the ambulance comes in. All of our facilities have a designated stroke gurney. It's a weight gurney, and it's near the telestroke monitor, and it has the stroke book with all the row cards, and that's in a designated area. So we always have the equipment ready and everything there ready for that stroke alert. Again, having that integrated EMR makes it more seamless as far as orders, documentations, and if we're pulling in teleneurologists, I mean, not just teleneurologists, but if we need to pull in a neurosurgeon, our NIR docs, again, we're all in the same EMR. We can Teams people in, making that communication really easy. And again, all of the physicians are working in the same medical group. We're a little bit different on how we do our telestroke. Our telestroke physician, as you can see on the screen, meets the patient when they arrive or soon after arrival. So they're working very closely with our ED physician and the stroke team to do the NIH stroke scale. You get the story and get eyes on the patient before they go to CT. So off to CT is the next step. We laugh, and this is again Sacramento, which is it's an old hospital. It's over 50 years old. The CT scanner is right behind this person right here. This is actually Dr. Klingman, and this picture was taken from a training video that when we rolled out the telestroke program, we did a very nice stroke alert video showing how a perfect stroke alert should go. But the CT scanner is right behind him, which we laughed saying we built the CT scanner there, who known that we were going to need it for stroke, but of course there was no CT scanner 50 years ago. We also developed a stroke alert database in MIDAS. This is a separate database than Get With The Guidelines, and it's all about the stroke alert. We way overcall stroke alerts, has all of our stroke alerts in there. It uploads daily from the EMR. We have our notes we use notes that are templated, so it can pull up it pulls mainly from the telestroke note as far as the stroke alert, but we also pull from other areas in the medical record. Again, it's a daily upload, and again, this is a system-wide stroke alert database, so each hospital has their own views. But then from a region, we can look at a regional view and we can look at individual hospital performance. We can also track in physician performance as well. So for our physicians that are who take telestroke call, we can see how many hours are they doing, what their complication rates are, their treatment rates, all the time metrics, time to decision, those sorts of things. So we can track and compare performance across physicians as well as across hospitals. This also allows us to print a stroke event summary that includes all the time points, including the 90-day modified Rankin. Since most of our patients stay within the system, again, our comprehensive stroke center and our primary stroke center can chart on the same patient, enter data on the same patient into the stroke alert database, which allows for good communication. And in that stroke alert database, we also have things such as, was the patient prepped before transfer? So we expect our primary stroke center to do a groin prep, make sure that the clothes are off except for a gown, etc. So all of that is tracked now also in our stroke alert database. Again, looking at those areas that for performance improvement, it's not just getting the patient to the comprehensive stroke center, but the bigger thing we're looking at is when did they hit what was the time when they hit our first hospital to the time where we're puncturing the groin. And then over the years, we've continued to refine and strengthen our stroke system, and a few milestones that have made a real difference. I mentioned the early adoption of Tenecteplase. This, change, as you know, is a simpler administration. I should also note that our pharmacist mixes drug and brings that to the emergency department. So when our doctors are telling neurologists to seeing that patient prior to going to CT, if it looks like a good case, they will pre-mix the drug and bring it to the CT scanner. It's so much easier just to train our pharmacists than to train thousands and thousands of nurses. And our pharmacy has a very quick turnaround time. And they were pre-mixing Tenecteplase, even though we know that if we weren't going to use it, there was no reimbursement at the time when we started that. But we made that decision because we think that was the best for the patient. In 2021, we implemented the Stroke Navigator in Health Connect. This is similar to the Code Blue narrator, and it is a one-stop documentation tool for stroke codes, and it captures all the critical time points in real time. And this has also been a major advance in standardizing how nursing documents care across all of our facilities. That was a little harder implementation. Currently, only 2 of our facilities are permitted to call 911 directly for interfacility transfers. that really helps. And Michelle's going to talk about their experience, and they do get to call 911, but they have also done so much other PI work besides that. All of our other hospitals go through a centralized call center. So we have a in-house call center that's regionalized for calling ambulances. It's called our ambulance transfer center. In 2024, we expanded. We did some work at the transfer center, and they did a pilot to improve the transfer of neuroscience patients, and that really made a big difference. We want a one-call process for transferring patients. We want to reduce the handoffs in trying to get in coordinating ambulance transfers. We also made another change in 2024. And this was, we have our telephysician now making the ambulance request directly. And all you can say, it's not really a physician's responsibility to organize transfer. It really was the quickest way. Those decisions are being made in the CT scanner. So getting all the information to the clerk, whoever's going to be making those phone calls, too many handoffs, missing information. So the physician has all of the information needed for that transfer at their fingertips. So they quickly, once they made a decision, this is endovascular, it's going to be an endovascular treatment, they make the phone call to get the transfer going. There are a few times when we'll pre-notify, but that is not a consistent process. That's a case by case. In 2025, we've also added Viz.IA, and that's mainly to aid in our external transfers. Again, we try to keep most of our patients in-house, but down in the Central Valley, there is now a couple of new comprehensive stroke centers that are closer to our facilities than our Kaiser centers. And so, it makes sense to transfer them as long as we can transfer in a timely manner. So Viz.IA is enhancing that coordination and communication, especially when we're dealing with different systems. And then one of the things that I think is one of our strengths is communications. We communicate a lot. All of at our local hospitals, they have monthly stroke meetings. They have additional meetings to do stroke reviews, stroke case reviews, stroke call reviews. Monthly, all of our stroke coordinators at all of our facilities get together. We have a monthly regional stroke coordinator meeting. Our tele-stroke physicians meet monthly. Our stroke leadership meets regionally monthly. We also meet with regional leaders. Our stroke medical directors and coordinators regionally meet quarterly. Our Comprehensive Stroke Center and our Thrombectomy Center have a monthly meeting to review cases, process improvements, to evaluate care on our different facilities. So again, that culture of constant communication, again, we're all one team. So if there's a problem at a hospital, they can reach out to our regional physicians. It's a very collaborative relationship that we have with everybody. So when there's a problem, it quickly gets escalated. And we also share across 21 facilities. We share there's a competition, but we also share our learnings, which I think is extremely important. And this slide shows, now this is our goal for month of October. 58% of all cases from our 21 facilities are being transferred in less than 75 minutes. When we look at year to date, it's 49%. We had kind of a rough winter last year, and that's a rolling year. For the 49%, I'm sorry, for 0 to 6 hours, 36% for the extended window, and 44% overall. When Jeannie heard this talk, we were actually doing quite a little bit better than you can see. We've been a little flat, but you can see on that bottom graph, you can see the improvements that we have made over the last 2 years. For the longest time, if you look back prior to the end of December of 23, and if this graph went back for the longest time, we were in the 20th percent of getting patients out. Then we kind of got stuck around the 30%. but now we've been up in the 40s. And again, this is a rolling year, and again, we're at 58% at this point. When you look at our individual facilities, there is a fair amount of variability. And so you can see the blues are the hospitals that are doing really well. We have a couple on the cusp here. And again, these are rolling years. So if you were to look at their individual performance month in the last couple months, it may look a little bit different than a rolling year. But what our leaders and everybody is held accountable to are these rolling years. Now, some of these, like in the 40s here, I think what's really exciting about this is one hospital was very low over a year ago, and they're saying this is really an impossible goal. We can't do this, and they're now just a few cases away of getting over the bump. Another one was had a fairly low performance a couple years ago, and they had new leadership in the emergency room about 2 years ago. And they're on fire, really, really good. And they're in an area that's also a little bit hard for transfer. So having to transfer across county lines, etc. Again, they're just on the cusp. Then some of our other ones down, like one of the ones in the 20%, this was one that was just flat forever. And this last year, in the last couple months in particular, they've had some phenomenal cases. So, they're coming up the leaderboard. Down at the very bottom here, these hospitals are the ones down in the Central Valley, and most of these cases now are being transferred out to more local facilities instead of within our organization, and we're working closely with our outside partners down there to improve our transfers. So now I'm going to turn this over to Michelle, who is going to talk in more detail on how one of our top performing facilities has shortened their time and remains on top. So Michelle, it's all yours.
Hello, my name is Michelle Williams. I want to thank you all for having me today. I am one of the managers here at Kaiser Roseville ER, and I oversee the stroke program. So as Pat mentioned, we are one of the top performing sites in the Kaiser system. What makes us unique is our ability to partner with EMS for a 911 transfer to a comprehensive stroke center. So a little background of our department is we see about 140,000 patients a year, which makes us the second busiest ED in the state of California. We also average about 1,500 ambulances a month, and we see about 25,000 pediatric patients a year. We are a stroke and STEMI receiving hospital, and on average, we see about 400 patients a day. So here at Roseville, we have 61 licensed care spaces, but we're able to flex up to about 110 care spaces with the use of our hallway beds and our chair care space. So in 2022, our team performed a stroke improvement process focusing on our door to needle and our door in, door out DIDO times, standardizing and streamlining the process to improve patient care. So at Roseville, we have a dedicated triage nurse, ambulance nurse, and stroke nurse. So depending on how the patient arrives, either a walk-in or by ambulance, the triage nurse or the ambulance nurse will greet the patient upon arrival. That's the first person that they see. Both will utilize the BFAST tools for early identification of a potential stroke. And then when the ambulance radios in with the stroke patient, the nurse will ask for the medical record number so that we can activate teleneuro as soon as possible. We track the patient arrival to teleneuro times so that we can make sure that we are activating as soon as possible. So our goal time for our walk-ins is 6 minutes, and our goal time for ambulance patients is 2 minutes. And the goal is set lower for the ambulance patients because we are able to get the medical record number and get the process started immediately. Next slide. Once we have identified for a potential stroke, the patient is placed in our designated stroke area. So this all takes place in the ambulance lanai. So we have 2 to 3 gurneys. They're set up ready to receive stroke patients at all times, as well as 3 teleneuro monitor screens. We have 3 teleneuro monitor screens because we can get multiple strokes at the same time throughout the day. So within this area is all the items that's needed to care for these patients, such as workflow checklists, stroke packets, IV supplies. And the stroke nurse is responsible for the care and the documentation of the patient. The stroke nurse will also initiate the initial phone calls to CAT scan and to pharmacy to have them ready the TNK and to ready the CT tables. Here you can see a picture of our stroke checklist that we created. So this lists everything that's needed to care for either a TNK or an LVO patient. The stroke nurse also utilizes the narrator within the electronic medical record for documentation. So within the stroke narrator, we created favorites to allow the nurses to efficiently move through the documentation needs. And then this checklist that you're seeing is a way to double check that they've completed all the necessary steps. Next slide. The initial intake and assessment occurs in the ambulance Lanai, and then we transport the patient to CAT scan. And along with the stroke nurse and the patient, the teleneuro will stay on the screen. Another nurse and an A&M go to CAT scan. So once an LVO is identified, the teleneuro will announce it to the team and obtain the accepting doctor. Our A&Ms were responsible for calling the 911 to set up the stat urgent transfer to the Comprehensive Stroke Center. The stroke RN is going to then transport the patient back to a code room in the ED and start prepping the patient for transfer. So clip the groin, get them undressed, update the vital signs, put in a Foley catheter if there's time that allows for that, and document the assessment. The ED clerks will go into the chart and they'll fix all the hard stops on the chart, so it allows the nurse to remove the patient once they're in the care of the medics. It's important to remove the patient from the tracker as soon as they're in the medic's care to allow the IR team to easily pull them into their system upon arrival. One thing that we've created is the use of a smart phrase that takes place of our phone call for nurse-to-nurse report. So this SBAR format phrase allows the IR nurse to review it in the chart without the need of a phone call. And this overall decreases any delays in transfer because they're not waiting for somebody to pick up the phone on the other end. This here is a picture of our A&M audit tool for all of our door-in, door-outs. We audit 100% of our door-in, door-outs and our door-to-needle time cases. These audit tools here assist the A&Ms to ensure everything is completed and documented. And then it also allows us to track any areas of opportunity. So what went well, what were some of the delays that we had. Once the phone call is made to 911 and the EMS arrives, the A&M completes the transfer paperwork and we transfer the patient to the medic's gurney. As soon as the patient is on the gurney and in medic's care, we'll remove the patient from our system. The A&M will call the house supervisor at the Comprehensive Stroke Center to alert them the patient is on their way. And the IR team will be ready and waiting to accept the patient. So as I mentioned before, we audit 100% of these charts and we work very closely with our hospital stroke coordinator, Michelle Arroyo, and we drill down on each one of these cases. This helps us improve on our processes. And as you can see here, the line graph, it shows areas that needed a closer watch. So some areas of opportunity for us when we started this process was, like I was talking about before, the arrival to teleneuro time. If there's a delay in that, that overall delays the patient getting either out of our system or getting SYNEC to place within the goal time. The acceptance of the 911 call was another one. We are not like Morris Avenue, like Pat was talking about, where the CAT scan is right where the patient enters into the system. We have quite the distance to our CAT scan. So when our whole team is in CAT scan and they identify that it's an LVO, that A&M has to leave the CAT scan and walk back to the department so that they can make that phone call to 911. And then lastly, the handoff to medics discharge. So if the medics are sitting in the ED and we're not working on transferring the patient and doing a handoff to the medics right then and there, that also ultimately delays the patient getting out of our hospital and over to the Comprehensive Stroke Center. So by drilling down on those areas and watching our goal times, we were able to tighten up our process. Since 2022, we were able to increase our percentage of transferring patients out of the department to a Comprehensive Stroke Center under 75 minutes. From 73% in 2024 to 87% in 2025. And on the next slide is the example that we get from our hospital stroke coordinator. This is what she puts together from us for every case. And although we do our audits from like the orange form that I showed you from us, Michelle Arroyo provides this, and this is shared with teleneurologists. It's shared with the Comprehensive Stroke Center and the ED doctors, and we can debrief on all these. So as you can see in the bottom left corner, you can see the pre-procedure pictures, and then after the extraction, you can see the perfusion. So now I'm going to turn it back over to Pat.
So some of the strengths that we have are is that streamlined stroke alert process and transfer process. That pre-notification and rapid activation, triggering that stroke alert, the parallel workflows has really helped us with our improvements. I think the integrated communication and infrastructure that we have is extremely helpful, especially having our telestroke see the patients before they go to CT scan. I think it's different than some other telestroke programs, having the standardized clinical pathways, regionalizing that, having a lot of using a lot of checklists based workflows, I think has been extremely helpful. Our data transparency and performance feedback, and then that strong interfacility and EMS partnerships. Michelle just showed an overview of the combination of both what happens at the primary and the comprehensive center. That is shared again because everything is uploaded on a daily basis into our stroke alert database. So there's real-time feedback. And I will say the hospitals within our system that do the best are the ones that have really strong emergency department leadership. Michelle talked a little bit about how their volumes, their ER is small for their volumes. They are expanding their emergency department. There's a building going on, but they see it's extremely busy ED that wasn't built for the volumes that they have, but they have such strong leadership, both for nursing. Their physician, who's their stroke champion, is extremely strong, gets into the weeds. The stroke coordinator is really into the weeds. They dissect every one of their cases for opportunities. And I think that is the high performing hospitals. That is, that's part of the special sauce that makes it happen. And then we do have some further, like all hospitals, we have further opportunities. One of the things that we're working on is faster telestroke decision time, pre-ordering ambulances, pushing, working a little closer with EMS. When we first developed this process, we did fast bundling, and we did some more mocks with the ambulance companies on that faster handoff and out the door. So we still have opportunities there. We still have some opportunities for we have limited resources, so like helicopter transfers for some of our further away hospitals. I think those are some of our being more accurate when we're discharging patients. We lose time there because there's delays sometimes from the clerk taking the patient out of the system. And then we also have, I think, some of our opportunities is when we're transferring to outside our facilities. We want one stop. We want you to pick up the phone and tell us yes or no. We don't want to go through 3 or 4 different phone calls, and we don't want a phone call coming 30 minutes later. And then lack of transparency for non-hospital transfers. But in conclusion, we don't have not all of our hospitals at 75 minutes, but collectively, we have shown that it can be done. It is still an ongoing challenge, but it is achievable. In each facility does have, even though we're a large system and we like to standardize, I think each facility does have some unique barriers with EMS availability, transfer distance being some of the biggest barriers. But in closing, we've made remarkable progress. We've had a lot of internal wins. We have a very collaborative approach, and we've made collaborative improvements along the way. And as an organization that's grounded in high reliability and patient-centered outcomes, we recognize the effort, and we're ready for this challenge that is still ongoing to ensure that we're saving every brain cell that we can. So we'll stop there for questions.
Wow. Okay. So you guys have, there are a ton of questions. I'm going to try to get to whatever we can. Not questions because you didn't answer them. Everyone's just so intrigued. And what a wonderful example of consistent communication, vigilance, and persistence on your part. So I'm going to group some of these.
Mhm.
There's a
Okay.
lot of questions about TNK use. So, do you not use critical care transport when you're transporting a patient who has TNK? And how many TNK vials have you wasted by premixing? And is there now reimbursement? That's
There
great.
is, okay, so I'll start with the first one. Yes, Genentech, I think, just started reimbursing it was in the last couple of months. Yes, we were wasting a lot of Tenecteplase. And if you think about 21 hospitals and the large number of stroke alerts that we call a year, um, it was very large, very large number. So we did look at it. We were monitoring it in the back. Pharmacists mainly were monitoring it in the background. But yes, that was it. Really, we didn't actually get even though we're a very cost conscious organization, we really did not get a lot of pressure from that. For the waste, and now we get to be reimbursed. So that's really good. Most of our EMS agencies, there's only I think 2 counties that require um, critical care transport if you've given Tenecteplase. Most of our counties, as long as there's not a drip going and the blood pressure is stable, we do not need to do critical care transport. As long as there's no drips going, we're good to go. Critical care transport, again, I think everybody knows EMS has been really busy. It really, if we need a critical care transport, it really delays a transfer out the door.
Okay, great. So there's a lot of kudos around your EMS work. So as a system, how do you gain an audience of attention from your EMS services as they work with multiple health systems? And then there's another EMS question around, did you say that you could call 911 for intrafacility transport?
So we only have 2 facilities that are allowed to call 911 for interfacility transports. And one of them is the Roseville Hospital that Michelle just talked about. And then we have another one down in the south area of San Francisco, South San Francisco, that can call 911. We wish we could call 911 for all of our facilities because it is an emergency, but we are only those are the only 2 counties that allow us to do that.
Okay, Michelle, there's a question here for you. Does your department designate a portion of your time for QI activities, or do you just make it work?
Yes. So we pretty much just make it work depending on the day. We have committee members. So we have about 20 committees that are going on in the ER, and our stroke committee. They are the ones that work with me, and since they're the boots on the ground, they bring ideas up, and we do monthly meetings. So our department does allow for committee work as long as we can fit it within the department needs and the schedules.
Okay, great.
Jeannie, I just want to go back just real quick and mention something else about EMS. So we have also a regional EMS medical director that helps us also with EMS issues and kind of oversees it for the Kaiser system. Of course, we do have some of our DD physicians are also EMS medical directors, but they have to wear, separate hats when they're doing that. And then just a kudos to, we have 2 stroke coordinators that co-lead the EMS stroke committees for their counties. So I want to do a kudos for Kalani and Kelly in San Francisco, who co-lead those EMS groups.
Fantastic. Okay. You mentioned that your ED physician calls for transport directly. Do they call transport or do they call the transfer center? And who tracks the time of decision to transfer when the doctor calls the ambulance? Who tracks the time? It's often difficult to find in the chart.
That has been very difficult to find. So it's our telestroke physician actually who calls the ambulance center. because they are, they're on the screen. The screen's coming up. It's like, oh, there's an LVO. They are calling in the NIR doctor and they're saying, yep, it's a go, let's go. And so the tele-stroke physician has all the information at their fingertips. We're still in CT scan. So they're just going ahead. They're calling our internal ambulance center, who is then arranging transfer. And so that was hard for us to track. It's still not perfect, but they are now putting a note in the EMR because it's all internal. So it allows for that better communication. So we get a note in the EMR and it is keeping track that the ambulance was called, and also estimated time of arrival. Because before, what was happening, it was like telephone tag, right? Somebody would get the phone call and it would get to some people, but not everybody. And then nobody knew the updates. So it is in the time tracker in the EMR. Not always accurate, or, sometimes it says ambulance is coming in 20 minutes and, it's 20 minutes and it's still not here. But that's how we're tracking some of it. And then we do have our ambulance because it's internal, they do keep numbers as well. So if we have problems and we want more additional information, we call our transfer center and ask them for the times.
Okay. There's two questions about your data. Are these results for patients transferring just within the Kaiser system, or is this all transfers? And then one says, does this data include patients who will not receive intervention, or only those who will actually be undergoing endovascular therapy?
So the data that we showed, over 95% of our cases, are probably even higher than that, stay within the system. So it is showing our internal transfers for the most part. And it does not, if a patient gets transferred and say they get to the comprehensive stroke center and, their NIH is 0 now, or they've greatly improved because we gave them tenecteplase, and now they're not going to get endovascular stroke treatment, they're not shown in those numbers.
Does your entire system have the ability to obtain perfusion imaging?
Yes, we use CT perfusion as our preferred diagnostic because it's we're already in CT, so we can go to we do CT, CTA on the majority of our patients, and then while they're still in the scanner, again, we're reading in real time. We have teleneurology, and we have our neuroradiologist reading the scans in real time as they're coming up on the screen. And then we can pull in the NIR position if we need to. The teams, they all have a chat looking at the imaging. So it's all done right there. We do have the capability of doing MRI, but MRI just takes a lot longer in our system. We have to transfer, and then most of our systems do not have an MRI tech in-house at nighttime, so they need to be called in. And one of our smaller facilities, there's 2 facilities under one license, they have to transfer to the other hospital. So we use CT perfusion as our preferred method, and all 21 facilities can do that in a very quick manner.
Great. Does your system have a Get With the Guidelines super user account?
We do. Yes.
Okay. There's a question here. Do you know how many telestroke doctors are serving your primary hospitals at one time?
So we have 2. When our physicians are doing telestroke, they do nothing else. They're on telestroke duty. We have 2 during the day and 1 at night.
I think you must have used the abbreviation AN as in Nancy M, and the person missed what that abbreviation stood for.
Oh, assistant nurse manager.
Gotcha. Okay. Can you share the smart phrase you developed to it? So I'm going to put this out there. You are getting tons of requests from both you and from Pat and Michelle about sharing your documents and all. And I never want to put presenters on the spot. So Pat was kind enough to share her email. So, that is a usually institutionally based, and I don't want to put them on the spot. So, but you are getting a ton of requests. Will you share your smart phrases? Will you share your documents? Will you share your resources? So I will put that.
Okay, we will probably need to get some additional permissions, but we can check on that.
Okay. We are hitting the top of our hour, so I want to really thank everyone for attending today's webinar. On behalf of the American Heart Association, I would like to, number one, thank our amazing, amazing presenters. I just am so impressed by the system and, once again, your persistence and your vigilance in really making a difference in your patients' care. So thank you, everyone, for joining us today, and have a great rest of your day. Well, everyone.
Thank you, everybody.
Thank you.